Very good morning, respected Dean, Research, Dr. Sarita Agrawal ma'am, Dr. Amit Chavan sir, Professor and HOD, Department of Pathology, my teacher, Dr. Rasika Gadkari ma'am, Professor and HOD, Department of Pathology, AIIMS Nagpur, Dr. Dave ma'am, other faculties of my department, the postgraduate student, paramedical staff, and the delegates who have joined us online all over the state. My topic is Bethesda system of reporting pap smear, adequacy, non-neoplastic condition, and squamous cell abnormalities. I am also supposed to cover in brief the collection and the processing of the smear, but that has been covered in most part by Dr. Sarita Agrawal ma'am, and I will be rushing briefly through these slides from the pathologist point of view. This is the plan of my talk. I just want to tell you that the primary objective of pap smear is to early detection of cervical precancerous lesion, which is a high-grade cervical intraepithelial neoplasm, and effectively treat them to prevent invasive cancer and decrease the cervical cancer mortality rate. As per the American Cancer Society 2020 guidelines, it recommends screening of women from the age of 25 years through 65 years of age for cervical cancer and precancerous lesion. WHO has declared its goal to eliminate cervical cancer worldwide by 2059 in highly developed countries. And WHO want to do it by triple intervention and want to screen 70% of the women twice in their life from the age of 35 to 45 years. Madam has told about the burden of the disease. As per the Globocan data 2020, cervical cancer, it is the fourth most common cancer with estimated 6 lakh deaths, 6 lakh new cases and 3 lakhs death worldwide. The condition in India is not better. There are 1,23,000 new cases in 2020 and 77,348 deaths in the same year. This comes to about 6,445 deaths per month. Now, every 7 minutes, one female dies from cervical cancer in India. What does this mean? It means that the disease of the burden is very high. If you consider this Airbus 320, it has the maximum capacity to carry 230 passengers. Now you imagine this plane full of females. Then such 28 planes, they are getting crashed every month without any survivor. Given this high burden of the disease in our country, we don't have any government-sponsored screening program to prevent these deaths. We can prevent these deaths because in most of the cancer cases of the cervix, the etiology is high-risk infection by the high-risk HPV. There is a long latent period between the infection and development of disease. The cancerous lesion, they do not develop in weeks or months. It takes about 8 to 10 years of time to develop the lesions. It is unlike other cancer, cervical cancer, it is a preventable type of disease, preventable type of cancer mortality if the lesions, they are detected early and treated. So there is a need to educate the female as well as females and their families for proactive screening. As per our own data, which is collected through the National Cancer Registry Program, which was started in 1981 through hospital-based and population-based registry, they have released this report in last year, Clinical Pathological Profile of Cancers in India, which also shows that the cancer of the cervix is the second most common cancer in the females, and highest incidence it is seen in the Arunachal Pradesh. Coming to collection of the pap smear, for conventional pap smear, we collect the sample with the help of spatula, Ayer spatula. It is a wooden spatula. Ayer was a Canadian gynecologist, and he suggested that the cervical smear, it can be collected directly from the cervical epithelium rather than from the vaginal secretions, which were originally described by Papanicolaou. He used this ENT speculum to collect the vaginal secretions. Now we have more improved devices to collect the samples from the cervico-columnar junction, or transformation zone. This is the cervical broom. This is the brush. Now when you collect the smear from the transformation zone, sometimes there is bleeding. To avoid this, we can fix this bleeding will get mixed with the material, and later on during processing it will hinder the examination of the cells. To avoid this, the slide needs to be fixed first in the cornice fixative and then post fix in the ethanol. But the problem with the cornice fixative is it has to be prepared every time fresh. While smearing the smear on the slide should be dirt free. There should not be any dust. The slide should not be too thick or too thin. If the slide is not clean, then sometimes there can be such extraneous material on the slide, and to which the cells they will get attached and they will hinder their subsequent analysis. The fixative that is used is 95% alcohol, and it has to be fixed immediately. Before the sample is sent to the laboratory, we need certain information like age of the patient, their menstrual history, clinical history, examination of the visual inspection findings, colposcopy findings if done, and previous diagnosis. Most important is the sample should not be divided and sent to two different laboratories. Many times the sample is divided, it is sent to the two different laboratories to cross-check the reports. But we do not know which sample will have the pathological cells or the pathology. So it is advised that the sample should be sent to one laboratory wherever the clinician wants, and if the second opinion is required, then slide can be issued. In this way, we can avoid the confusion and two different reports for the same patient. After the sample is received, this is the protocol that we follow in our laboratory. There are three stains. One is the nuclear stain, that is hematoxylin. Second is the OG6 and the EA50. These are the cytoplasmic stains. This is our staining area in our department. If the slide is well stained, it will show the nuclei blue, cytoplasm from pink to orange to turquoise blue. Keratinized cells, they will appear orange in color, and the WBC, they are blue. Next is the examination of the smear. Before you start microscopic examination, visualize the slide with your naked eyes. Now the first smear and the last smear, these are the conventional smears. Here the smear appear to be uniformly stained, uniformly sprayed, as well as uniformly stained. Whereas second and the third slide, they appear very thick and stained darkly. Other thing that you must check is the slide ID mentioned on the slide and the test requisition form. This is the LBC smear and the conventional smear. On microscopy, you have to screen the entire area under 4x magnification, assess the cellularity and the staining quality. The screening has to be completed in a systematic manner. It should not be random assessment of the areas on the smear. You have to go from one end to other and then come down, or you can move the slide vertically so that every cell is examined on the smear. These are our own cases which are stained by our technician. These slides, they show uniform spread of cells. The staining is bright. You can identify individual cells, their lineage, whether they are squamous or glandular. This is the LBC preparation. The time required for screening is around 20 to 25 minutes because the conventional smear, it contains around 8,000 to 12,000 cells, and in the liquid-based preparation there are around 5,000 cells. So for a beginner, it may take around 20 to 25 minutes. With practice, this time it can be lowered to, it can come up to 10 minutes. If you something abnormal on the scanner or the 10x, move to the higher magnification and mark the abnormal cell area or the abnormal individual cells, and then confirm your findings with the senior pathologist. Now, what are the normal cells that you will see in the Pap smear? We are taking the sample from the transformation zone or the squamocolumnar junction, which is lined in partly by the glandular epithelium, endocervical cells, and partly by the stratified squamous epithelium. So the cells which are lining these two epithelia, they will appear in the normal pap smear. So this is the ectocervix lined by the stratified squamous epithelium. Uppermost layer is the keratinized stratified squamous epithelium. As the cells they mature and progress to the superficial layer, they have more amount of keratinization. So these are the normal cells. I have taken this from the social media platforms, which has summarized all the cells, all the normal cells which are seen in the cervical smear. The normal cervical smear, it shows superficial squamous cells, intermediate cells, parabasal and basal cells, and the endocervical cells. Every cell, it has some individual characteristic. For example, superficial cells, superficial squamous cells, they are large. They have bright pink cytoplasm. Their nucleus is pycnotic. Some people, they describe the nucleus as the ink dot, and it occupies around 2 to 3% of the cytoplasmic area. Similar to, and these are seen under the influence of estrogen, they are more abundantly seen in the proliferative phase of the female menstrual cycles. The intermediate cells, they are also large in size, but here the nucleus is bigger than the superficial cells, and it has vesicular chromatin, and the chromatin is uniformly distributed. Parabasal and basal cells, they are small, round, and they have a bit high NC ratio as compared to the intermediate cells, as compared to the intermediate cells. Then endocervical cells, their morphology, it will depend on how they are oriented on the slide. If you look from the side, it will appear as picket fence appearance. And if you look them from the end face, it will have the honeycomb appearance. So this summarizes all the normal cells seen in the pap smear. Now, basic approach to cytology examination is same as we apply for the other samples. We examine the individual cell with respect to its cell size, cell shape, pattern of arrangement, cytoplasmic color and texture, and nuclear characteristics. Cytoplasmic features, they are important to identify the individual cell, to what type they are, whether they are squamous or whether they are glandular cells. Nuclear characteristics, they are important for diagnosis of cancer and precancerous lesion. I call this as a window of opportunity. Now, in the beginning, I told you that the cervical cancer of the cervix, in 95 to 100% of the cases, it is associated with infection by high-risk HPV genotypes. Now, this infection does not lead to precancerous lesion very early. There is a latent period, and these changes do not take place within weeks or months. It takes years. So this is the normal. First is the normal cervix. Then there is a immature metaplasia, low-grade squamous intraepithelial lesion, high-grade squamous intraepithelial lesion, and lastly invasive cancer. Now, if we can detect the lesion before it invades, it will be a great service to the humanity. And these females, they can be saved. First is the normal cervical smear. Then there are metaplastic cells, low-grade squamous intraepithelial lesions seen on the cervical smears, pap smear, and these are the very badly cells in the last. So our main objective is to detect high-grade squamous intraepithelial lesion, so that we can avoid the invasive stage of the disease. Before I come to Bethesda system of reporting pap smear, it will be very interesting to know what has happened before that. In our life, if we are fortunate, we come up across a person who has changed the destiny of their family, any village or a country. But some people like Dr. George Nicholas Papanicolaou, They have changed the destiny of the entire generations. He was born in Greece in May 1883. Since childhood, he was attracted towards the nature and ocean. He majored not in biology, but in music and humanities. But like any other parents, his physician father influenced him to pursue a medical career. He graduated with top honors. He has done PhD in zoology from the Munich University. He got married to this beautiful lady, Mary Andromache, who later on was known as Mrs. Papp. The most of the research work on which Dr. Papanicolaou has done his research, most of the samples on which Dr. Papanicolaou has done his research, they were donated by his wife. The couple was interested in career opportunities and they decided to immigrate to United States in 1930. And this was the bold decision of their life because neither husband nor wife, they spoke English and they hardly had $250 with them. That was the cash required to enter US at that time. Initially, they do not have any job. So the Papanicolaou worked as rug salesman, violin player at restaurant. His wife also worked in the departmental store. And in 1940, he finally got a position in the Cornell University's anatomy department, where his wife also joined as lab technician. The Papanicolaou, he began his studies with guinea pigs. And he was studying the sex chromosomes. He deducted that reproductive cycles in experimental animals, they could be timed by examining the smears of their vaginal secretions. He thought that the same principle, it could be applied to the humans. And he was very thrilled when he was able to see the differences between the malignant cervical cancer cells and the normal cervical cells. With excitement, he presented his observations in the first Race Betterment Conference in 1928. And the name of his paper was New Cancer Diagnosis. But his first presentation failed to spark enthusiasm among the pathologists and the gynecologists. Many pathologists at that time, they considered this method as superfluous because the cervical diseases at that time, they were diagnosed by cervical biopsy. So this was a major setback to Dr. Papanicolaou. So he gave up the concept of cancer diagnosis, cervical cancer diagnosis, but he continued to analyze the samples which were donated by his wife. He studied the hormonal effect on the cervical epithelium. And his work later on proved to be significant in the discipline of diagnostic cytopathology. This went on for a decade. So in 1939, Dr. Joseph Hinsey, he was the head of Department of Anatomy. He asked Dr. Papanicolaou to consider his concept of cervical cancer diagnosis after going through his impressive publication. Now, no pathologist can work alone, and Dr. Joseph Hinsey, he was knowing that. So he thought that Dr. Papanicolaou, he needs a clinical collaborator. So he introduced Dr. Papanicolaou to Dr. Trott, who was a gynecologist, and then teamwork of Dr. Trott and Dr. Papanicolaou brought this monograph, Diagnosis of Uterine Cancer by Vaginal Smears, after analyzing thousands of cases. This monograph and its follow publication, it captured the attention of the medical community. Dr. Charles Cameron, he was the director of American Cancer Society. He sponsored first National Cytology Conference in Boston in 1948 to showcase the effect of this method in diagnosis of cervical cancer as compared to the cervical biopsy. Slowly, this method, it got accepted, and then Dr. Cameron gave it the name Pap test in 1954. Later on in 1954, Dr. Papanicolaou produced another landmark publication, Atlas of Exfoliative Cytology, where he encapsulated all his experience about the Pap test and devised a system for reporting the abnormality in the cervical cells. He retired after serving about 40 years in the Cornell University. In 1961, he was given a chance to direct the Miami Cancer Institute. This research institute is named after him after his death. This is the original class system that the Papanicolaou has devised. this system, it got modified over years. There were many pathologists, they used descriptive term to give the report of pap smear. And those terms, they were borrowed from the histological classification of pre-invasive cancer. In 1953, Regan et al., he proposed the classification as, for the pre-invasive squamous lesion, as dysplasia. He graded the dysplasia into mild, moderate, and severe. Now, dysplasia and carcinoma in situ, initially they were considered two different diseases. Carcinoma in situ is a high-risk lesion comprised of undifferentiated cells, small cells, whereas dysplasia as a differentiated lesion and low-risk lesion. But this hypothesis became untenable because most of the cases of dysplasia, they progressed to cancer, and cases of carcinoma in situ, they regressed. To remove this dichotomy, in 1969, Reichert, he proposed another classification, cervical intraepithelial neoplasia, and he graded them into grade 1, grade 2, and grade 3. The problem with this classification was, on looking at only on the morphology, we cannot predict the biology of the lesion. So biologic behavior, it was not predicted, and treatment for all the three lesions was same. So there was a chance of over-treatment. In around 1980s, there were articles in the Wall Street Journal about the inconsistencies in the reporting of the pap smear. So NCI sponsored a meeting where the experts in the cytology, histopathology, and the patient management, they participated, and their goal was to devise a pap smear reporting system. This system should be uniform, and it should clearly indicate the abnormality to the clinician that will help in the better patient management. So the Bethesda system initially proposed a two-tier system. They classified the pre-invasive squamous lesion into a low-grade squamous intraepithelial lesion and high-grade squamous intraepithelial lesion. The atypical squamous cell, which were not fulfilling the criteria of LSIL or HSIL, they were classified as atypical squamous cells. Now, atypical squamous cell, it was very problematic for the pathologist as well as for the clinician. The additional workshop, they were held in 1991, where the recommendation from these workshops were to develop the criteria for the diagnostic term and the criteria for the adequacy, as a result of which the first atlas of Bethesda system for reporting cervical cytological smears, it was published in 1994. Then again it was modified in 2001. Now by this time, the pathology laboratories, they have started using liquid-based cytologies. The commercial HPV test, it became available, and this atlas then incorporated the images and the criteria which were specific to this preparation. The term diagnosis, it was replaced by interpretation. In 2014, again we have the update of this system. The main motive of 2014 was to provide updated atlas with the retention of popular features of the earlier classification, earlier editions. There was no new category for the lesion which shows LSIL and few cells suggestive of concurrent HSIL. So no new category was, but the age for reporting the endometrial cells, it was increased from 40 years to 45 years. This is to alert the clinician to investigate the patient to exclude the possibility of the endometrial hyperplasia and the endometrial carcinoma. Now, as compared to CIN classification, the TBS, it has classified the pre-invasive lesion only into two types. LSIL, which corresponds to CIN1 of the CIN classification and mild dysplasia, and HSIL, it corresponds to CIN2 and CIN3, or the moderate and the severe dysplasia. The cells which do not fulfill the criteria, I have already told you that they can be labeled as ASCUS, and the atypical squamous cells cannot exclude the HSIL. These are the 6 components of the updated Bethesda system 2014. It starts with whether the specimen, what type of specimen we have processed, whether it is a liquid-based cytology or it is a conventional smear. Then specimen adequacy, general categorization, interpretation. General categorization and interpretation, they are more or like same. And many people, they directly give the interpretation. Interpretation, it has two parts, whether the sample is negative for intraepithelial lesion or malignancy, or whether there is any epithelial cell abnormality. When epithelial cell abnormality is present, we have to say whether, we have to decide whether the abnormality is in the squamous cell or it is in the glandular cell. Ancillary testing, if performed, it has to be reported in this system. Then computer assisted interpretation, where the sample load is very high, we can use the computer assisted interpretation system, but still this is not widely used in India. And last is the educational notes. The criteria for satisfactory smear is we need well preserved and the well visualized cells. There should be 8,000 to 12,000 cells in the conventional smear, and in the liquid based preparation we need 5,000 cells. The presence of transformation zone is not necessary as per the updated 2014 system, but it acts as a quality indicator of the sample. Then more than 75% of the cells, they should be visualized. There should not be any obscuring element by the blood, mucus or the inflammation. There should not be any drying artifact. If the cellularity is less than 5,000 in LBC and less than 8,000 in conventional smear, then those smears, they are unsatisfactory for analysis. If the slides are broken, if there is mismatch in the patient information, then those samples, they are also called as unsatisfactory. Now, if we consistently report the presence of transformation zone in the sample or in our smear, then it acts as a feedback for the clinician or the sample takers about the specimen quality, and that will promote their attention to the specimen collection with consideration for the use of improved sampling devices. The presence of number of cells in the smear is not a very strict criteria in case of if the female is very old, having some atrophic changes, or she has undergone radiation therapy. Even if the number of cell is less, but if there are abnormal cells, then by definition, this sample is satisfactory for evaluation. These are the guidelines for estimating the cellularity in the liquid-based preparation. There should be at least 7 to 8 cell on the 40x magnification in sure path. The diameter of the smear is about 13 mm and it is 20 mm in thin prep. For the conventional smear, we have to assess the number of cells present in each field. For example, this is the scanner view and it contains around 1,000 squamous cells. So on a smear, there should be at least 8 such fields showing similar cellularity, so that the total number of cell count will be 8,000 on that smear. Here the cellularity is very high, but all the cells, they are overlapped by the inflammatory cells. We cannot visualize the individual cells, we cannot examine their individual characteristic and the nuclear characteristic. So this smear is unsatisfactory for evaluation. Another case, we hardly see any squamous cell in this smear. There are only polymorphs and the mucus. This is again an unsatisfactory smear. This smear shows well spread squamous cells. We can examine the individual cells, nuclear characteristic, they are crisp. Cytoplasmic features, they are very well visualized. So this is a satisfactory smear for examination. Now in the general categorization, there are 3 terms: negative for intraepithelial lesion, benign cellular changes, and epithelial cell abnormality. So general categorization help to triage the patient, and it clearly tells us whether the sample is normal or it is abnormal. These are some of the examples of the report. It shows what is the type of specimen, what is the specimen adequacy and interpretation, whether it is negative for intraepithelial lesion or there is presence of any abnormality. Apart from the epithelial cell abnormality, if there are some microorganisms detected on the smear, we do report them. But pap smear is not the primary modality for diagnosis of these microorganisms. Even if these are reported on the pap smear, we have to confirm our diagnosis by other methods. So the common organisms which are detected on the pap smear are the Trichomonas, Candida, bacterial vaginosis, actinomycosis, and cellular features suggestive of HSV or CMP. There are some case report where the people have also identified the microfilaria on the pap smear, which usually comes from through the seminal fluid from the male partner. The other neoplastic findings that are observed on the pap smear are the reactive cellular changes, which can be because of inflammation, repair, radiation, intrauterine devices. Second is the glandular cells status post-hysterectomy. Now, what does it mean? Cells status post-hysterectomy means the glandular cells, it should not appear if the uterus is removed, but still in some cases we find glandular cells. What are the causes of those cases that I will tell. Now here this is a pap smear from a 32-year female and it was sent for the routine screen. The nuclear features, it shows that the size of the nucleus is enlarged as compared to the intermediate cell nucleus. It shows prominent nucleoli, distribution of the chromatin is clumped but uniform, but the NC ratio, it is maintained. Size of the nucleus is also enlarged and size of the overall cell size is also enlarged. There is another smear from a 67-year female with history of prolapse. At the top, there is a group of endometrial cells and the squamous cells, they are arranged in sheets. Here the nuclei are also prominent. The cells, they are seen to move in one direction. So this is called as school of fish appearance. And these are the changes seen in the repair. Now prominent nucleoli is not a feature of pre-invasive squamous lesion. It can be seen in only two conditions in pap smear, either due to repair or due to frank squamous cell carcinoma. Pre-invasive lesion, LSIL and HSIL, they will not show prominent nucleoli. Exception is HSIL when it is involving the endocervical glands. So this is the school of fish appearance. Radiation, it causes enlargement of the cell. They also show prominent nucleoli. Cytoplasm appears dichromic. Sometimes you can also note multinucleated cells, vacuolization of the cytoplasm. They also show degeneration of the RBCs and cellular debris. When such changes are seen, we have to ask for the history and then you correlate your microscopic findings with the history. Such radiation-induced changes can be seen in patient up to 6 months after radiation therapy. In patient having intrauterine devices, and if the pap smear is sent for examination, sometimes we see these single such clusters of 10 to 15 cells showing cells with peripherally located nuclei and cytoplasmic vacuolation. Now these are said to be exfoliated from the endometrial cavity or from the endocervical canal, and these are shed because of the irritation, and they disappear after 3 to 6 months after removal of device. These are the causes for the glandular cells status hysterectomy, and the most and important cause when the glandular cells are seen post hysterectomy is either a wrong history or the wrong sample from the patient. The other causes are the partial hysterectomy, the prolapse of the fallopian tubes, and vaginal adenosis. When there are abundant parabasal cells on the pap smear, our diagnosis goes toward the atrophy. Squamous metaplastic cells, it can have the varied histology. It can be differentiated cells comprised of large cell having intermediate or superficial squamous type of morphology, or it can be undifferentiated small round cell. The differentiated cells, they show spidery cytoplasm, slightly increased NC ratio. Keratotic cells, they are also common if the patient has uterine prolapse. If there are immature keratotic cells, it can be indicative of HSIL. The other things that can be reported in the negative or intraepithelial lesion or malignancy category in the pap smear is the presence of endometrial cells. Endometrial cells need to be reported in patients who are more than 45 years of age. Endometrial cells, it can be a normal finding in a young female, or if the female is taking any hormonal therapy, or the other causes can be endometrial hyperplasia or the carcinoma. Endometrial cells on the pap smear, they appear as a tight ball of cluster. They have overlapping nuclei. Because of the overlapping of the nuclei, you cannot visualize the chromatin pattern. Sometimes in the LBC preparation, we get such exodus, where there is a central cells, they are the stromal cells surrounded by the epithelial cells. And exodus, it appears at a higher plane than the squamous cells in the LBC preparations. Then coming to epithelial cell abnormality. Epithelial cell abnormality, they are classified into either squamous cell abnormalities or the glandular cell abnormalities, and the other malignancies like melanoma, they are very rare. Melanoma or the metastasis from the adenocarcinoma of the intestine or from the adenocarcinoma of the rectum or malignancies from the urinary bladder. But these are very rare. The common are the squamous cell abnormalities and the glandular cell abnormalities. With improved devices that we are using nowadays, glandular cell abnormalities, they are detected more in frequency. So epithelial cell abnormalities, they are classified in varying in increasing grade of severity as atypical squamous cells. The pre-invasive squamous lesions, they are classified either as low-grade squamous intraepithelial lesion and the high-grade squamous intraepithelial lesion and frank squamous cell carcinoma. One thing we have to note that the high-grade squamous intraepithelial lesion, they are caused by exclusively by the high-risk HPV types 16 and 18. Whereas low-grade squamous intraepithelial lesion, they are caused by low-risk HPV types, HPV type 6 and 11, but many times they are also associated with high-risk HPV. Therefore, the low-grade squamous intraepithelial lesion, many times they regress when they are caused by the low-risk HPV. The transformation of the LCIL getting transferred to the frank carcinoma is rare, and therefore when we give the report as LSIL, most of these patients they are kept on follow-up, and these lesions many times they regress in a due course of time. Whereas the risk of developing the frank carcinoma is high with the high-grade squamous intraepithelial lesion, and therefore our main target of pap smear examination is to detect high-grade lesion. So the first category in the squamous epithelial cell abnormality is the atypical squamous cell. The forerunner of this category in the previous edition of the Bethesda system was the atypical squamous cell of undetermined significance. Now this atypical squamous cells of undetermined significance, it has a broad definition. So in 1996, there was a national survey in the United States where more than 700 laboratories participated to study the reporting pattern of the cervical smears. And this data from this survey showed that 5.2% of the cervical smears, they are of ascus. So this and the laboratories, they were not able to maintain their reporting frequency of ascus below 5%. So this prompted the development of new category, that is atypical squamous cell, which has a narrow definition, and in 2001 Bethesda system, it has a dichotomous simplifier as atypical squamous cell of undetermined significance and atypical squamous cell cannot exclude HSI. These atypical cells has to be mentioned in the report when they do not fulfill the criteria for the LSIL or HSIL. They are infrequent in number. They are less than significant. Then we have to mention it, and they have to be reported as with qualifier as atypical squamous cell of undetermined significance or atypical squamous cell cannot exclude HSI. Atypical squamous cell, it does not indicate any single biologic entity. The causes can be either the cause is unrelated to oncogenic HPV infection, or there can be possible presence of cervical intraepithelial neoplasia or rarely carcinoma. 50% of the cases with atypical cells, they are infected with high-risk oncogenic types, and therefore, if the report says atypical squamous cells, they are present, most of the time we send them for reflex HPV testing. The prerequisite for a cell in question to call it as atypical is the presence of abnormal appearing nuclei, and the cell, they should show three essential features, that is squamous cell differentiation, increased NC ratio, and minimal nuclear changes in the form of hyperchromasia, chromatin clumping, irregularity, and multinucleation. For comparison, you can use the intermediate cells nuclei for comparison with the atypical cell nuclei. This category, it was in the previous edition, it was a problem for the pathologist and the gynecologist for management. Pathologists, they were not able to make black and white decision on the cellular specimen. And for clinician, the problem was whether to treat the patient or not to treat the patient. Because if we write ASCUS, the clinicians, they were compelled to investigate the patient by colposcopy. And colposcopy, it required expertise, it is not cheap. And if you do not report ASCUS, there is a chance of missing the lesions, missing the benign lesions, which can be high grade. So this problem was sorted out after 2001 when HPV testing it became available. To call the cell as atypical, we need enlargement of the nuclei, and nuclei they are enlarged 2.5 to 3 times than the area of the nucleus of the normal intermediate cells. They show minimal abnormality in the nuclear characteristic, like clumping of the chromatin, or the nuclear membrane is bit irregular, it is not very smooth. Many times while doing the routine reporting of the pap smear, we come across this question where the nuclei, they appear very enlarged, and we are posed with the question whether to call it as a reactive change or the ASCUS. So this is the one useful tip, that if the nucleus is enlarged up to 3 times and there is minimal nuclear hyperchromasia with minimal irregularity, it should be called as ASCUS. If there is only enlargement without any abnormality in the nuclear characteristics, it should be called as reactive. Then atypical squamous cells cannot exclude HSIL. This designation, it is applied to very small number of cases. The cells, atypical cells, they show the features of HSIL, high-grade squamous intraepithelial lesion, but these cells, they are very sparse. They are very few in number. So they are designated as ASCUS. This is a small group of cells in a 35-year female. The cells, they are smaller in size, but the nuclear abnormality is marked. The nuclei, they show irregular nuclear membrane. There are nuclear grooves. It was designated as atypical squamous cells, cannot exclude HSIL, and the follow-up biopsy, it showed high-grade squamous intraepithelial lesion. Another case, again a single group in the center. The cells, they are small in size, nuclei, they are overlapping, and nuclei, they show abnormal nuclear membrane, there is indentation. So this is again classified as atypical squamous cell, cannot exclude the HSIL. The low-grade squamous intraepithelial lesion, the accepted terminology on the histopathology is mild dysplasia, pilocytic atypia, and chyliocytosis. The criteria is the LSIL, it affects the superficial cells, which are present in the superficial layer of the squamous epithelium of the cervix and in the middle layer. These cells, they are large in size. Here the nuclei, they are still bigger than the atypical squamous cell. Nuclear enlargement is equal to or more than 3 times the intermediate size cells, nuclei of the intermediate size cells. Cells, they occur singly and in clusters. Overall cell size is large. Nuclei, they are generally hyperchromatic, and nuclear chromatin, it is uniformly distributed, or sometimes it may be clumped. Sometimes you can also see the binucleation and multinucleation. But nucleoli, they are absent, generally absent. Now, chyliocytosis, it is also included in the LSIL on the Pap smear. For a cell to call as chyliocytes, there should be a perinuclear zone of clearing. Along with that, the peripheral cytoplasm is condensed, it appears very thick. Only presence of the perinuclear zone is not sufficient to call it as a chyliocyte. There should be a nuclear abnormality to call it as a chyliocytic change. Then high-grade squamous intraepithelial lesion. Here the cellular cell size is small and NC ratio is very high. Nuclear characteristic, they are markedly abnormal. They are hyperchromatic. Nuclear indentation, it is present. These are some of the mimics of HSIL. They can mimic like a parabasal cells, histiocyte or decidualized stromal cells. These are the characteristic of the HSIL. Then coming to the last, that is squamous cell carcinoma. Here, as compared to the HSIL, LSIL or the atypical squamous cell, abnormality in the smear is very marked. Cells, they are variable in size. Nuclei, they show prominent pleomorphism. They show prominent nucleoli. The chromatin pattern is very abnormal. It is very clumped. Some of the cells, they are very spindle or tadpole shaped and showing orangiophilic cytoplasm. So diagnosis of squamous cell carcinoma in a very frank cases is easy, but many times it is difficult to differentiate ascus, reactive cell and the LSIL. This is the summary of the atypical squamous cell changes in the Pap smear. I will like to, these are some of the research work done in our institute in the last few years on the cervical cancer. I will like to end my talk from a quote by admiring author, which he has written in 1998. He has summed up the contribution by the Papanicolaou. He says his monumental contribution proved that cancer can be beaten. The Papanicolaou screening test will remain one of the most powerful weapons against this disease. Those of us who looked upon him as a guiding star will always owe him our gratitude, and those women who were helped by his test owe him their lives. These are some of the references. I express my gratitude to all my teachers because of whom I am here. My professor and head of the department, Dr. Amit Kumar Chauhan sir, all the faculty members of the Department of Pathology with whom I work every day, to all my residents and postgraduate students whose query keeps me motivated to read more. And this is my technical team of working in cytopathology. Thank you for your patient hearing.